But welcome everybody. And tonight, just like the title says, is understanding dysautonomia, right? And some of you may be familiar with this term. Some of you, this may sound like a completely foreign language. Either way, if this seems like a foreign language, we'll kind of introduce you to this concept. And for those of you who have heard of this before, hopefully I can shed some light on a very difficult condition that not a lot of people know a lot about. And not a lot of people have very successful treatments for this condition. So it can be a very, very difficult condition to have and even just to get diagnosed, okay? So let's get started. So some of you may know who I am. Some of you may not know me at all. So I'm Dr. Perry Maynard, and I'm one of the clinicians at Integrated Health Systems in Inglewood, Colorado. So about 15 minutes south of Denver, so a suburb of Denver. So I have training in rehabilitation of traumatic brain injuries. I have training in vestibular rehab or inner ear rehab. I have a lot of training in functional medicine and more so kind of functional immunology. I'll talk a little bit more at the end of more conditions I see, but I'd say probably about 80% of my patient population is all traumatic brain injuries, individuals suffering from vertigo, dizziness, balance issues, or really any kind of neurological ailment. That neurological ailment could have come from a traumatic brain injury, could have come from a tumor, from a stroke, from neurodegeneration, or things like MS or certain types of dementia. So it doesn't really matter how you got there. We strive to try to figure out kind of what's going on, why it happened, and then work on ways to rehab or improve functionality. So that's a little bit about me. So dysautonomia, what is it and what does it include? So dysautonomia is kind of a blanket statement for dysfunctional autonomic nervous system. Okay, and in the next slide you'll see all the things that the autonomic nervous system controls. But pretty much you can think of the autonomic nervous system is a system of your body, your brain, and your nerves that controls all the systems in your body that are all automated, that you don't really have conscious control of. And you could argue that about some of these, but they're all reflexive things. Things like heart rate, things like blood pressure, things like sweating, getting cold hands, cold feet, so constriction of blood in and out of different limbs, your gut. It's hard to control the motility of your gut and how quickly your bowels move. Things like urination, bowel movements, saliva that's produced in your mouth, right? All these unconscious things, right? That is your autonomic nervous system. So when there's dysfunction in that system, it is categorized as dysautonomia or dysfunction in the autonomic nervous system. And you can see underneath it is an umbrella term. And underneath that term, you have more specific terminology or more specific conditions. Some of the most common that are seen clinically and that we see clinically are POTS, or postural orthostatic tachycardia syndrome. And I'd say orthostatic intolerance, right? And we'll discuss a little bit more the differences between those two just because they're the most common. But you can see you have neurally mediated hypotension, which honestly I think you could put under or mix with orthostatic intolerant, neurocardiogenic syncope, pure autonomic failure, familial dysautonomia, multiple systems atrophy, which is something you see more in Parkinson's plus syndrome. So you can see dysautonomia in a variety of conditions, and one of them is Parkinson's or certain types of Parkinson's patients. And this is this MSA or multiple systems atrophy. And then autoimmune autonomic ganglionopathy, right? So you can have autonomic forms. So pretty much your brain can cause it. You can have autoimmune disorders against nerves in your body that can have it. You can have certain neurodegenerative conditions in your brain that can create it. There can be some genetic causes, and you can see it a lot of times after infectious or post-infectious diseases, viral infections, bacterial infections, things like that, okay? So what systems of the body can dysautonomia impact? Well, let's see. Fatigue, dizziness, cognitive impairment, vertigo, dry mouth, dry eyes, impaired gut, heart racing. You can see that literally dysautonomia can affect any system that it controls. So once again, the autonomic nervous system controls the brain. It controls certain aspects of the mouth, certain aspects of the eyes. The heart is largely controlled by the autonomic nervous system. The gut is largely controlled. The gallbladder, your colon, your bladder, and your immune system, right? So no wonder why individuals with dysautonomia are so miserable, or also no wonder so many people go so long without an appropriate diagnosis, right? Because it can literally manifest in any organ, and you have to figure out, is it more related to the nervous system, or is it something wrong with its organ itself? So you can see it's a very difficult condition to identify, and that it can affect a gamut of different systems. Pretty much almost every system in your body, dysautonomia can affect. So these can all be symptoms of dysautonomia. And individuals with dysautonomia may have two or three of these symptoms. Some of them have almost all of them, right? So it really ranges from patient to patient, okay? So let's talk a little bit about POTS. And in this slide, I'll also talk a little bit about orthostatic intolerance. And the reason I'm going to talk about POTS is I'd say this is what I see most clinically, especially after TBIs or head injuries. And I'd say it's probably, even if you look at the literature or the research, it's probably one of the more common forms. So I'm not going to go into depth talking about, these rare genetic conditions that I've never seen and that not many people see. I want to talk about the things that really affect a majority of people. Okay. So POTS stands for postural orthostatic tachycardia syndrome. So postural, it usually affects patients when they change position. So going from lying to standing, seated to standing. Orthostatic, right? So that's that changing of positions going from lying to standing. And then tachycardia, which is heart racing. Okay. So these are individuals that stand and they feel like their heart is going to beat out of their chest. They may feel like they're going to faint. They get really anxious. Honestly, a lot of the symptoms that you see with hangovers, or if you drank too much, or maybe partied a little too much the night before, right? A lot of those symptoms are symptoms that patients with dysautonomia experience on a daily basis, right? So you can see how miserable it is. So what is the diagnostic criteria? How do we know if someone has POTS? Okay. One of them is that the heart rate rises more than 30 beats per minute within 5 to 30 minutes upon standing. Okay. So like we said, the heart really shouldn't beat more than like 10 to 15 beats. Medical literature accepts anything under 30. So 20, 25 is normal. I would argue most people start to notice symptoms when they get like 15 to 20 beats. So you might not be able to categorize them as having POTS, but I notice patients get dizzy or lightheaded when they stand, usually when it goes above 15 or 20. So technically, to call it POTS, it's got to be above 30. I don't like anything above 15 to 20 beats per minute upon standing, right? It's a pretty simple task and it shouldn't exert a ton of effort. It's not like you're walking up, a flight of stairs, okay? The other thing is blood pressure may or may not be affected. So sometimes blood pressure may stay normal. Other times it may decrease. But blood pressure doesn't have to be part of the diagnostic criteria, but it's important to look at. Unlike an orthostatic intolerance, when individuals stand, if their blood pressure drops more than 20 systolic, so systolic is the top number, so when we say 120 over 80, 120 is the systolic number, right? So if that drops more than 20 points, and diastolic by 10. So say someone's lying down, their blood pressure is 120 over 80. If they stand and it drops to 100 over 80, that's orthostatic intolerance. Or maybe it goes from 120 to over 70, that's orthostatic intolerance. Now, once again, I'm a little bit pickier. I don't really think blood pressure should drop really that much at all. I mean, initially it's going to drop because when you stand, blood is going to pool in your feet. But as we talk about later, you should have feed-forward predictions from your brain to keep that from happening. So within 30 seconds to a minute, I would argue your blood pressure should be the same, and if not more, because now you need to increase constrictions of blood vessel to get blood to the brain so you don't faint or pass out. Okay. And then these are some other things that you really only see more so in the research, but standing plasma norepinephrine, right, which is a stress hormone, greater than 600. So one of the theories with POTS is you get this over exaggerated sympathetic response that is too much, right? And that oversympathetic response gives off too many stress hormones, and that can create some of that tachycardia or that heart racing, okay? And then the other important thing is that it has to be in absence of things like anemia, hyperthyroid, which is too active of a thyroid, prolonged bed rest, dehydration, or medication, right? So all these things can mimic and make it look like you may or may not have POTS. And I've seen this before where individuals get diagnosed with POTS and they may be anemic or they may be on a certain medication, right? So these are really important things to take a look at. I see there's a question. I will, so that's a great question. I will come back to that at the end. So we'll go through everything and then I'm going to answer any questions that people have at the very end. Okay. So, let me change slides. Perfect. Wait, let me make sure that I didn't go too far. Perfect. So, like we talked about, so pathophysiology, which is just a fancy word for why do things happen when we study them. Okay, like we talked about, one can be what's called neuropathic deinnervation to sympathetic nerve fibers. Okay, so remember when I talked about that autonomic ganglionic form, right, or autoimmune form, right? Also things like diabetes or anything that affects nerve fibers or small blood vessels, right? And that's why diabetes is probably one of the most common, can also create things like dysautonomia. So throughout your body, you have all these mini nerves that go to your blood vessel, your legs, so that when I stand, I have sympathetic nerve fibers in my legs so that when I get the signal that I'm standing, my muscles contract, my sympathetic nerve fibers in my legs should go crazy because I want to vasoconstrict or I want to make my blood vessels narrow so that I can increase blood pressure and get blood to my brain. So if I have damage to those nerves from an infection, an autoimmune disorder, diabetes, whatever it may be, I'm going to have damage to those sympathetic nerve fibers so that when I stand, I don't constrict my blood vessels and I get pooling. This is where people get like purple feet or swollen feet, or they may get edema with standing because there's some sort of issue with those nerve fibers in their extremities. Okay, that's an important thing to analyze when examining a patient. Another thing is hypovolemia. So anything that alters blood volume. Okay, so blood pressure is really made up of a few different things, but one of them is blood volume. So the balance of sodium, potassium, magnesium, chloride, all those things help to regulate blood volume. So if an individual is dehydrated, that can create low blood volume and give you POTS-like symptoms or dysautonomia. You can have alterations in what's called the renin-angiotensin aldosterone cycle, which is pretty much the cycle that plays a role in increasing and decreasing blood pressure via altering sodium reuptake in the kidneys. Okay, and there's actually interesting when you look at things like infection, especially with COVID, right? COVID can affect this system, and certain infections can affect this renin-angiotensin aldosterone cycle and create some of that hypovolemia or that low blood pressure, which is a way that infectious disease or viral infections, post-viral infections, can create things like dysautonomia. And then there can be a whole slew of other things that can create hypovolemia as well. So decrease in proteins in the blood, all these different things, right? And these are things that we can look at in blood work, right? So as we're looking at a patient with dysautonomia, we have to start checking all the boxes saying, do they fit this box? Yes or no, okay? And just start ruling things out until we can find where do they seem to fit in, okay? And then this is probably what I see most often, just because seeing a lot of head injuries, is central hyperagenergic POTS, okay? Once again, I don't look at norepinephrine in different positions. I really have only seen that in the research. It'd be cool to be able to, but it's hard to find labs, and I think it's pretty expensive. But these are more of the patients where it's something's going on in their brain. Something's going on in the centers of their brain that regulate autonomic function. And we'll talk about those a little bit more in a second, right? And that's what you see affected a lot of times with TBIs, okay? And then another thing, kind of a new diagnosis that's on the scene, is what's called mast cell activation syndrome, okay? Mast cells are certain types of immune cells that release things like histamines, prostaglandins, different kind of inflammatory molecules, but also vasodilators. So if you've ever gotten hives or an allergic reaction and all of a sudden you get red and itchy, that's from mast cells, okay? Certain individuals have overactivation of mast cells, which creates excessive amounts of vasodilation, right? Which kind of alters blood volume, but not necessarily, but it will decrease blood pressure, okay? So that's where we have to look at a patient and say, what do their allergies look like? Do they have a history of asthma? Do they have hives? What's going on in their GI system, because you have mast cells in your GI system as well, right? So all these things can give us windows and say, maybe it's their mast cells creating their dysautonomia. Maybe it was a head injury from a few years ago. Maybe they're just dehydrated. Did they have an infection? Do they have diabetes, right? All these things are very important. And I find time and time again that a lot of people or a lot of doctors don't pay attention to these things, okay? And it's very important. So what does clinical testing look like, okay? So history, I'd say, is very important. History is almost the most important with any condition. But this is where we can tease out, like we talked about, different forms or different things that can create dysautonomia. Figuring out, do they have nerve damage? Do they have small vessel disease? Do they have things like diabetes? Do they have a history of autoimmune? Does it seem like they may have mast cell, right? So history is very, very important, right? So taking a detailed history. Now, I'm not talking like a 15-minute history you get, usually at the GP. I'm talking, 45-minute history where we're really sitting, breaking everything down, okay? And then examination, right? And we'll talk a little bit on this later, but doing a full neurological examination, physical examination, listening to the heart, the lungs, listening to individuals' bowel sounds, and then doing even other kind of diagnostic testing that can give us more of a window into brain function. All those things can, mixed with a history, can let us start thinking, maybe this is where it's coming from. Next thing is lab testing. So you can look at certain mast cell markers. Like I said, plasma or epinephrine, I don't ever look at that. But just looking at basic blood work. So what's called like a CBC or a complete metabolic panel. This helps you look at immune function, red blood cell function, look for anemias, look how your kidneys are doing, how your liver is doing. So all these basic things that would let us know, is there maybe an infection? Is there something going on with their immune system or mast cells? Are they just dehydrated? What's going on with their kidneys? So just some basic blood work, and sometimes we'll dive even deeper if we need to. Okay, and then most importantly is just a line to standing vitals. You would be surprised how many doctors, how many patients just take vitals seated, right? All we really care is your blood pressure under a certain amount. If you don't have hypertension, you're good to go. There's not many doctors I've found that actually look at vitals dynamically. So we take them seated, and then we lie individuals down for 3 minutes, take them there, and then have them stand up, and then take and monitor their blood pressure and their heart rate for about 3 to 5 minutes after standing. And we want to see, does their blood pressure go up? Does it go down? Does their heart rate go up? Go down? That's probably the best clinical marker that there's some sort of dysautonomia. And then you have to figure out what type it is. Okay. And then tilt table testing. Some of you may have been to a cardiologist and they did kind of standard tilt table testing where they lock you in a table. Sometimes they'll give you certain medications and then they'll flip you up and sit for a while. It's a pretty brutal test for individuals with dysautonomia, but it's a good test. We'll do similar tilt table testing in our clinic, but it's a little bit more functional and it's not as dramatic or not as intense because sometimes I don't think it's got to be that intense to really see what's going on. So we'll do kind of our own form of tilt table testing in the office. And like I said, it's different than the standard that you get at a cardiologist, but I think it gleans the information you need without making people feel very, very sick. So let's talk a little bit more on the physiology of blood pressure and heart rate, right? So why would this even happen, right? And I want you guys to know this, and some of you might have some experience in physiology. Some of you, this may just be absolute jargon. And I want to try to simplify it for you so you can start thinking about why you may be feeling the way you feel or why a loved one may be feeling the way they feel, okay? So if you think about it, when you stand up, you have to fight gravity. Gravity is anyone with dysautonomia, their biggest enemy is gravity, right? People with dysautonomia love to lie down, they don't like to stand up, okay? So when we stand, upwards of 500 milliliters of blood volume drop into our chest cavity and into our lower extremities, right? So as we stand, gravity takes that blood and shoves it into our feet. Okay, 10 to 25% of plasma, which is a part of blood, shifts into what's called your interstitial tissues. So pretty much it just floods into your tissues. This is why people sometimes with dysautonomia get swelling in their feet. They get bluey in color, their feet get really enlarged, their hands get really swollen. That's fluid going into the interstitial tissues. Okay. And then there's a decrease in arterial pressure and cardiac filling. Okay, so if you think about this, you have a big vein that comes from your lower extremities and it comes into the right side of your heart. Okay, when you stand, blood drifts away from that area, right? So you have less blood in what's called your atrium. So you have a decrease in atrial pressure, and that makes sense. Gravity is taking it down. Okay, this decreases the amount of venous return to the heart. Okay, so your heart all of a sudden gets a signal saying, hey, we're not getting as much blood or pressure. What's going on? Okay, this decreased activation to what are called baroreceptors. So baroreceptors are pressure receptors in your heart and in all of your arteries, especially your carotid artery, which is the artery up in the front of your neck. When you stand, those say, there's less blood here. What's going on? And it signals that to the brain, and the brain says, we must have stood up. Okay, we need to activate our sympathetic or our fight or flight nervous system, and we need to constrict blood vessels, and we need to increase volume, right? So it's a beautiful system. It's complex, but also simple at the same time. But when it goes wrong, and it's not good, right? So we have to figure out along that whole physiology, where is an individual's system broken, right? Where's the kink in the armor? So there's a huge connection between your heart and your arteries and your brain, right? And when that disconnect happens, whether it's due to damage to arteries of the heart or damage to the brain, you can see where that system goes awry, okay? This is just a fancy, cool picture. Once again, we're not going to go over it. I don't expect anyone to fully know what it means, but it's kind of a cool picture from a paper looking at all of the brain connections that have to do with controlling blood pressure or heart rate. So it pretty much shows us that your vestibulosympathetic pathway, which is pretty much just a pathway from your inner ear, a lot of research is showing that your inner ear is one of the most important pathways in regulating upright heart rate and blood pressure. And it's the fastest, right? Your kidneys are another one, but they're too slow. Okay. So your vestibular system or your inner ear is one of the fastest systems to let you know that you went from lying to standing. This is why a lot of people with head injuries who are dizzy or have vertigo or have visual problems also have dysautonomia. And a lot of times it's because there's dysfunction in that vestibular system so that it makes them dizzy, but it also doesn't allow them to control sympathetic tone in their blood vessels. So now they have dysautonomia, right? And those pathways affect baroreceptors, okay? And then you have different parts of your brain, one called your cerebellum, that has a ton to do with coordination. So when individuals damage their cerebellum, let's say from a head injury or a stroke, they may have balance issues, coordination issues in their arms and their legs. The problem is that system has everything to do with setting that central tone of controlling blood pressure, heart rate. So now you can start to see how brain injuries can create dysautonomia, or just dysfunction in people's brains can create dysautonomia, right? And there's one other thing I want to point out is you'll see there's a box that says limbic system and hypothalamus, okay? Your limbic system is your emotional brain. This is where things like stress, anxiety, can further make things like dysautonomia even worse. So you can start seeing all of these different pathways into all of these blood pressure centers in the brain and how they can affect that. So really cool picture. I love this picture. Okay, so let's talk a little bit more about the brain, or how I kind of think about dysautonomia when it comes to patients. Okay, so two systems that I think about and I want you to think about: feed forward and feed back. Okay, what does that mean? When I go to stand, I have to make a prediction of what is about to happen. So if I'm sitting in my chair and I want to stand, I know I want to stand before it even becomes conscious thought. And I've rehearsed that pattern upwards of 10 to 20 times. So my brain says, okay, he's going to stand. Okay, he's going to use this leg first. We're going to need to put this much force into the ground. He's going to stand this quickly. Okay, that calculation, we should need this much blood at this fast up to the brain, right? So you make all of these predictions, okay? And then you have what's called feedback. So when I stand and there's alterations in pressures in my arteries, my heart, my tissues, that feeds back to my brain to say, was my prediction appropriate or was it not appropriate? And if it wasn't very good, I may get tachycardia, or I may get faint, or I may get all of these different compensation strategies. So it's really important with individuals. Let's say we've ruled out autoimmune disease, infection, whatever. Let's say it's more brain mediated. These are really the two mechanisms. So we have to figure out, is it a predictive mechanism or is it a feedback issue? So more of a neurocardiac connection. Okay. So how do we look at this? Well, both will have a positive sit to stand test. So both patients will stand and have alterations in their heart rate and their blood pressure. They'll get symptomatic. The difference is usually the feed forward group will have a negative tilt table test, and the feedback group will have a positive tilt table test. So some of you may have been given the diagnosis of dysautonomia, but your tilt table test is fine, but you still get dizzy every time you stand, right? Because if it's truly a more of a feed forward or a prediction standpoint, if I put you in a table and I move you passively and you can't predict how I'm moving you, it doesn't really matter what your prediction is. There's nothing to really compare. When you do a tilt table test, all you're doing is you're pooling blood in the heart, out of the heart. So as you go line to standing, standing to line, you're changing how much blood is going in and out of your arteries, and you're seeing how well that feedback system between your heart and your brain can work, right? So that's a big thing when you say, their tilt table test is normal. What might be going on? Okay. So when we look at more feedback systems, we're looking at more lower brainstem areas, the vestibular system, baroreceptors, right? And these patients respond really well to tilt table therapy. So you guys might be thinking, I thought tilt table was only a test. Well, you can use it therapeutically as well. If I bring you up and at 20 degrees, you start getting your heart racing, what I can do is I can start tilting you from line to 10 degrees. And we go up and down, and then we go a little farther. And we start training your heart and your blood vessels and their communication to your brain and start making that stronger till eventually I can get you to 20 degrees, 30 degrees, 60 degrees, and eventually all the way up, right? And now we've really rehabbed that feedback system, and it's really in tune now between your heart and your brain. Okay, so people with feedback issues do really, really well with tilt table therapy. Individuals with feed forward don't really do as well because it's not an issue in the feedback system. We have to figure out, why are they making poor predictions, right? And a lot of times you can see this with a lot of concussions. When there's alterations in the inner ear, the visual system, the cervical spine, whiplash, dysautonomia and whiplash go hand in hand together. Or maybe these are individuals who just have really poor spatial awareness of their body, right? If you think about it, if you don't really know where your limbs are or your body is, how are you supposed to send blood flow to it, right? So this is where with individuals you start saying, maybe we need to start looking at other broken systems. And if we fix those, maybe they'll have a better prediction and now they don't get dizzy when they stand up. Okay, so we're going to briefly touch over these. So I talked about this is for when we're thinking about when issues have more of a feed forward or prediction issue, right? So these are individuals, once again, who stand, they get dizzy, their heart races, but their tilt table test is normal. Okay, we have to start thinking, does this patient know where they are in the world? Okay, so we're going to think about 3 reference frames. And those of you who have listened to me speak on dizziness and inner ear, this is going to sound very familiar because it's the same thing. Right? Your head reference frame, or what gives you a map of where your head is in the world, is your inner ear. So how do you know where your head is in gravity? That comes from your inner ear. Okay. Do you know where the world is relative to you? Okay, this is an eye reference frame. So if I'm sitting at my kitchen counter and I want to grab the cup in front of me, how do I know that cup's there? Right? I have to have a visual reference frame that's built off of my head reference frame. So first I need to know where I am, and once I know where I am, now I need to know where the world is in reference to me. Okay, and then this next one's actually really important for dysautonomia. It's important for dizziness imbalance as well. But where is my body in reference to my head? And this is the cervical spine. And this is why whiplash a lot of times can create dysautonomia, is that my inner ear says, here's my head. But how do I know where my head is relative to my arm? My neck. My neck lets me know, is my trunk left? Is my trunk right? Is my head right relative to my body being left? Right? And this is where I've seen individuals where they just have a simple whiplash injury and their arm turns purple. And you're like, why would their arm turn purple? Well, they lose integration from their neck to their head and they lose track where their body is. And now they don't know how to control blood to the rest of their body. So sometimes fixing one's neck or doing things to improve proprioceptive input to one's neck could fix someone's dysautonomia, right? But a lot of individuals don't think this way, right? And this is more when it comes to TBIs, right? Because TBIs or concussions are more functional injuries. Everything becomes a little wonky. There's a lot of weird crosstalk. It's kind of like in Charlie Brown with the teacher that's like, won't, 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 right? The brain has no clue what the system is saying, right? So we need to find where those mismatches are and make that system a little bit more clear, right? So your inner ear, your eyes, and your neck, and even your whole body can also contribute to dysautonomia because of a lack of spatial awareness, okay? So I'm not going to go super in detail into this because I want to leave time for questions. In my lectures on vertigo, I go really in depth into this, but this is talking more about the head reference frame. So talking about your inner ear. Am I tilting? Am I translating? Is my head left? Is my head right? So that's an important reference frame, right? So where are you in gravity? World reference frame, right? Where am I relative to the world, right? This comes from your eyes, but is built off of what your inner ear says. So if your inner ear is broken, that can give you visual symptoms. I see this all the time. You fix someone's inner ear issues and their visual symptoms go all away, right? And this is my problem sometimes with, certain lenses or prisms I think can be very powerful for patients. But if it's an inner ear issue and their visual system is fine, but it's just not giving them good input because their inner ear is broken or their neck's not working, that's not the best strategy in my opinion, okay? And like I said, I talk far more about that in my vertigo lectures, okay? And then head versus body reference frame, okay? So your neck is telling you where's your head relative to your body, right? These are all things that are really important when it comes to head injuries, and head injuries creating weird functional disconnects in the brain and creating things like dysautonomia, okay? So where do we go from here? Right? We talked about a ton. You go to a million doctors and no one knows what to do. Okay. This is where we talked about comprehensive health history, lab work if it's appropriate, full examination, physical, neurologic, orthopedic, looking at your eye movement. So what's called VOG testing, which allows us to look at inner ear reflexes, eye tracking. Balance testing. Balance testing is huge when it comes to dysautonomia because balance testing really lets you know how well is your inner ear, your eyes, and your neck communicating together. Once again, if you have disconnect between any of those 3 systems, that is a recipe for disaster and things like dysautonomia, right? And then cognitive testing as well, because like we talked about, certain neurodegenerative disorders, especially Parkinson's plus, can also create things like dysautonomia, okay? These are kind of some other conditions that we work with as well. So I'm going to wrap up because I know there's some few questions. So I want to open up to some questions so we can talk more. Like I said, I work with a lot of post-concussive syndrome, migraines, like I said, neurodegenerative conditions, inner ear disorders, things like MS, movement disorders like dystonia or certain tremors, dysautonomia, like we talked about. And then you can see some other more metabolic conditions on the right-hand side because autoimmune disorders and chronic infections are really pertinent to brain issues. Okay. So my conclusion before we answer some questions is it's really important to act sooner rather than later. The longer individuals go with a lot of these things, the more difficult it is to make recoveries. And it creates so much emotional stress and things like that. But the other important thing is that it's never too late. I come across so many patients that say, I've been everywhere, no one can help me. I would argue when it comes to things like dysautonomia and concussions, there's always someone. There are a bunch of amazing people out there. Uh, great clinics all around the country that I know of, that I work closely with. So there's hope everywhere. Whether you're in Denver, whether you're in Chicago, Boston, wherever it may be, don't give up hope. Okay. And then also, we offer free consultation. So if it's something we're saying, hey, I don't know if they can really help me, give a call. We can chat. I can go through your questions. We can review your lab work, and I can say, hey, yeah, I think we can help you. Or, hey, I think this person would be a better fit, or maybe you should go down this route first, right? So it's really, really important. It costs you nothing but your time, right? So I really think it's important that people remember that it's never too late. Okay, so let's look at some questions. So the first question, once again, if you have any questions, just feel free to write them in the attendee chat and I'll get to them one at a time. So the first question is, can you address at some point, can stress make POTS worse? I developed POTS after brain surgery 3.5 years ago. I'm a lot worse now and wondering about stress, COVID, etc. So great question. So we touched on that a little bit earlier, but yes, stress can definitely make things like dysautonomia and POTS worse, right? Because some form of dysautonomia is alterations in your sympathetic nervous system, right? So your fight or flight system. And remember we talked about that limbic brain or that emotional brain has huge integration into what's called the hypothalamus, which then integrates into all the brain centers that has to do with blood pressure, heart rate, things like that. So stress definitely can affect it. Stress also will affect the kidneys, all these different things. So, stress management or finding maybe reasons why there's overactivation in one's stress system can be really, really important to manage that. Because I think sometimes saying just, manage your stress is too simple of a term, right? We got to figure out why individuals may be stressed. And that could just be traumas or thoughts on the world, or it could be literally their emotional centers of their brain aren't being regulated. So we do have some patients where you say, they have a lot of anxiety. They have a lot of depression. They have all these emotional issues, and then they have dysautonomia. And then they have maybe, let's say, some alterations in the executive areas of the brain that regulate emotional networks. Well, you can do things to try to improve executive function in the way things like the frontal lobe or different things like that integrate into some of these more limbic emotional centers, which in turn could make someone's POTS better if their POTS is being made worse by things like stress. Okay. And then COVID and et cetera. Yeah, COVID, I haven't seen, I think we've had a few of our patients that have had COVID, but I haven't really followed up with them since. So I haven't seen a lot of post-COVID patients, but I guarantee it. I mean, I see things like Epstein-Barr virus, cytomegalovirus, things like Lyme disease is very, very common to create dysautonomia. So infections do it all the time. And the fact that COVID affects individuals' lungs and their kidneys, so it literally affects the cycle that helps to regulate blood pressure and heart rate, I guarantee you it's going to create POTS in people. It's going to create dysautonomia in all sorts of people, which is scary. And I think that's an important thing that a lot of people aren't thinking about with COVID is there's going to be a lot of people that even if they survive, could have a lot of long-term issues, right? And that's because of how it affects the lungs and the kidneys, but also we're learning more and more that it affects the brain and it can create things like meningitis. So it can create almost like a chemical TBI, right? Or a lot of neural inflammation, which then can lead to dysautonomia as well. So I definitely think COVID and infectious diseases are really, really important. And this is why a lot of individuals, we have to see, are they still getting their butt kicked by infections? So we can look at different immune markers, different what are called natural killer cells, T cells, all these different things to kind of look at where someone's immune system is. And sometimes maybe addressing that could make their dysautonomia better. So I hope that that answered your question. The next question is, how might this relate to something convergence insufficiency after TBI, along with dizziness, fatigue, etc.? So that's a great question. So convergence insufficiencies are very common after TBIs. What's very fascinating about convergence issues is individuals with TBIs can sometimes have convergence insufficiencies or what are called convergence spasms, to where their eyes come in and then they get stuck in. What's interesting is that the center of the brain that controls convergence is right next to the center of your brain where you have a lot of sympathetic drive. So convergence happens in an area of your brain called your mesencephalon or your midbrain. That's also where you have a lot of your different pathways for sympathetic drive, right? So a lot of your activation from your brain to activate your sympathetic nervous system comes from your mesencephalon or your midbrain. So that makes a lot of sense that if you think of it like neighborhoods, if that part of your brain can't really control your eyes coming in and out, maybe it's not doing a great job controlling your autonomic nervous system. And that's where sometimes fixing things like convergence insufficiencies or convergence spasms can actually make dysautonomia significantly better, right? And coming back to dizziness and fatigue, individuals with convergence insufficiencies, sometimes that can be, once again, damage to the muscle or the nerve that controls that eye or that area of the brain, or sometimes alterations in inner ear circuits can create convergence insufficiencies as well. So your eyes, your inner ear, and your neck are literally hardwired together. Any individual who doesn't look at all of those are definitely missing the boat for sure. So the dizziness could be related to the insufficiency. So there could be an inner ear thing that is creating the insufficiency. They could be two totally different things, but they all definitely can blend together. So your convergence centers also control sympathetic tone, right? So your ability to constrict blood vessels. And then your dizziness could be related to some of that alterations in sympathetic tone, or your dizziness could be something completely separate. Or once again, if you don't have great control of your eyes going in and out, you may have some other visual tracking issues as well that could create the dizziness, right? And then fatigue with TBIs can be a few things. One can be that your brain goes from being an efficient fuel source like a Prius. So it goes from like 40 miles to the gallon to like a gas guzzling truck. So your ability to use things like glucose, proteins, fats becomes kind of altered. So that can be a cause of fatigue. Another can be damage to some of the executive areas in your brain that have to do with executive function. But what I'd say more commonly than not is when individuals are dizzy, that creates so much fatigue because their brains get so exhausted from trying to figure out where they are in the world, right? A lot of times when I get rid of a lot, my patients' dizziness, their fatigue a lot of times goes away or gets significantly better. Not all the time, but that's usually where I start, is I work on the dysautonomia, the dizziness, the visual tracking issues. And when you can improve those, a lot of times fatigue goes away, right? But that's where we also look at blood work to make sure there's not anemia, thyroid issues, right? So really there can be numerous reasons why, but that's what we make sure that we really look at those in detail. So I hope that that answers your question. So I just meant stress from COVID. Sorry. So I guess I went on a little tangent of COVID. So, yep. So stress from COVID is just like stress from, going through a difficult time at work. Stress, when your brain has stress, it just thinks it's kind of running from a lion. So it really doesn't matter if the stress is coming from someone's boss, from a COVID situation. Stress is stress. So stress from this COVID situation can definitely make a dysautonomia worse, because like we talked about how those emotional centers connect to your blood pressure centers. So I hope that answered both of your guys' questions. If for the one question about the dizziness, like I said, I have a lot of lectures on dizziness, vertigo, TBIs. You should definitely go back and watch those. That might help to answer some of your questions as well. So any other questions that we have? Let's see. If we don't have any other questions, then thank you all so much for joining. I hope that you guys were able to take something out of this chat, whether it's for yourself or a loved one. If you have more questions, like I said, don't hesitate to reach out and call. You can have a free consultation where we can just chat. I can answer questions for you or a loved one. Like I said, don't wait. Get help from somebody, whether it's myself or myself guiding you in the right direction of a doctor that will work really well for you. That's really important. And for those of you in Denver, myself, Dr. Stedman, and Jake are on the radio every Monday at 12:30, where we talk about various topics. So you can catch us there. And then the other important thing before I wrap up is we offer telehealth. So for individuals who don't feel comfortable coming into the office due to COVID, we can do a lot of things via telehealth. So don't think just because COVID you can't get help. There's many, many options and ways. So thank you all so much for joining. That is it. And like I said, if you have more questions you think of tomorrow, feel free to call the office and set up a time and we can chat and I can answer those questions for you. If not, have a good night, everyone. Stay safe, stay healthy, and have a great week. Okay, bye.